Welcome to part 2 of the ankle. If you haven't already reviewed ankle part 1, we recommend that you do in preparation for part 2. So in part 2, we will continue to present you with a series of fracture cases to help develop your learning. We will also consider Bohler's angle, and finally we will look at some anatomical variants.
It's important when we're evaluating the lateral image that we carefully assess the fifth metatarsal. And that's because the peroneus brevis inserts at the base of the fifth metatarsal. And frequently when people sustain an avulsion fracture there, what happens is the effusion runs up the peroneus brevis, and that peroneus brevis tendon runs over the lateral malleolus. So what happens is you get gross swelling of the lateral malleolar region, and people will then frequently mistake it for a lateral malleolar injury rather than a base of the fifth metatarsal. So if we look carefully at this image, we can see quite a defined lucent line through the base of the fifth metatarsal, indicating that the patient has sustained a fracture here. And if you look carefully, you can see that there's really quite gross soft tissue swelling both anteriorly and posteriorly. So what is it? It's a fracture. Where? It's at the base of the fifth metatarsal of the left foot. How? Slightly displaced. I've touched upon this earlier in part 1, but we're going to now look at this in a bit more detail. We can see that there's no evidence of a fracture. The fibula is intact, as is the tibia. And yet, when we look at our mortise joint, and our normal mortise joint should be 4 millimeters or less of the medial, superior and lateral clear space. And here we quite clearly have a diastasis of the medial clear space, so it's more than 4 millimeters. Therefore, we know there has to be a further injury which has allowed the talus to shift laterally. So what's happened is that there is a proximal fibular injury, and the injury has ruptured up through the intraosseous membrane to further up to the fibular fracture, and this has meant that the ankle joint has become unstable and has allowed for lateral shift. Lateral talar shift. So if you ever do an ankle x-ray view and you see this diastasis but you don't see a fibular fracture, then you need to go on and repeat and do full length tibia fibula views. And now on the lateral view we can just see this sharp piece of the fibular fracture. So you now need to have full-length tibia fibula views to be able to visualise the entire fibular fracture, and also make sure that you can clear the fibular neck. And now we have full-length tibia and fibula views, and we can see much more clearly now that fracture of the fibula, which has occurred around about the junction of the mid to distal third of the diaphysis of the right fibula. So this type of injury is called a Masonry fracture, and what that means is that you have an injury to the ankle joint and a contracule fracture, usually of the proximal tibia further up. And it's important that you do recognise that this injury in the ankle joint to ensure that we don't overlook the high fibular fracture. Now this fracture is also very interesting on this particular case, because actually if we look at our lateral view we can see there's actually quite a large butterfly fragment. So we use the term butterfly fragment for a large triangular portion of bone. Now, in this particular case, although it's important to refer to it as a butterfly fragment, in this particular case, because it's a fibula, they're not going to put an intramedullary nail down this patient, because that, well, one thing wouldn't fit, but also fibulas are quite interesting in that they only serve a purpose through the ankle joint and through the proximal tibiofibular joint. Other than that, it doesn't actually have a great deal of importance with regards to weight bearing. However, should a patient sustain a butterfly fracture within, say, for example, a tibia or a femur, then that becomes really significant, because that patient will have to have an intramedullary nail, and the surgeon needs to know about the butterfly fragment, because as they bang the nail down through the patient's bone, it will have to pass through the proximal portion, through the butterfly fragment, and out through the distal portion. So when you identify a butterfly fragment, it's really important to comment on it in your what, where, how. So what is it? It's a Mason nerve fracture, where it's at the junction of the mid to distal third of the diaphysis of the right fibula. And how? So you've got a butterfly fragment, and you need to mention the lateral talar shift, because then you're telling, you're recognising the fact that there is a further injury down in the ankle. So let's just go into a little bit more detail about a Mason nerve fracture. So what you get is you get a medial malleolar fracture or ligamentous injury, and then you get a high fibular fracture. So this is your classic example of a vagal injury. So you get a break at one half of the ring, and then you get either a break or a ligamentous injury at the other portion of the ring. So with our previous case that we looked at, we had medial diastasis of the medial clear space, but no evidence of a fracture. So we had a medial ligamentous injury, and then we had that high fibular fracture. And sometimes that high fibular fracture can be as high as the fibular neck. So if you ever see an apparently isolated displaced fracture of the medial malleolus or diastasis of the medial clear space, or if you see an isolated displaced fracture of the posterior malleolus. Now, if you think back to that posterior malleolar fracture that I showed you, it wasn't particularly displaced. So you're looking at a displaced fracture of the posterior malleolus, and or diastasis of the lateral clear space without evidence of fracture. You then need to do full-length tibia and fibular fuse. That's really important. A penile fracture is a fracture of the tibial plafond, and it classically has gross comminution, and basically it's caused by this axial force. So usually people falling from height, or like significant car crashes and so on and so forth. Interestingly, the fibula is usually spared, but because it's an axial load, you may get other injuries with it, so fractures of the calcaneum, fractures of the lumbar spine, and so on and so forth. And essentially what happens is that the talus smashes its way through the tibial plafond, causing this really gross comminution. And now on the lateral view, we can see how it's been displaced anteriorly. There's also a horizontal fracture running through the posterior malleolus. You can see the gross soft tissue swelling. This dark black area is referred to as Cage's fat pad, and essentially what's happened is that you're getting obliteration of the fat pad due to the large effusion. Now don't get confused, you might see this little tiny osseous body adjacent to the posterior calcaneum. What happens is that this is your Achilles tendon inserts into this location, and you can get what's known as enthesopathy. So enthesopathy is degenerative changes to tendons and ligaments, and what's happened is they've just got a little bit of calcification within the tendon there. So this shouldn't be misconstrued as a significant traumatic part of the trauma complex. You can tell that because it's nice and round, and also just because of the location there. And you can see that there's no rupture to the to the Achilles tendon. If you saw ruptured Achilles tendon, you get really marked soft tissue swelling, and you get this kind of notching up here superiorly. That's from the retracted tendon. So what is it? It's a pilon fracture where it's the distal tibia and posterior malleolus, how it's comminuted and it's intra-articular. So it's really important in this case to talk about the comminution, because these large osseous fragments, the surgeon needs to know about those when they go to fix it, and more importantly that it's intra-articular, and that's perhaps one of the key definitions of a pilon fracture, that it is intra-articular. A quick refresher of Sultaharis classification. You do need to learn this, it's really important, and I can appreciate it can be quite challenging. So Sultaharis classification is used in paediatrics before their growth plate fuses. So Sultaharis 1 is slipped. So what happens is that your physis contains unossified cartilaginous cells, and these cells are actually really quite slippy. So when you sustain a fracture through the physis, what happens is that the metaphysis or the epiphysis will slip. And that's a Sultaharis 1. Sultaharis 2 is a fracture through the metaphysis. So this is the most common fracture, Sultaharis 2, in paediatrics. And it's really important that this metaphyseal fracture extends to involve the physis. So if you have a metaphyseal fracture that doesn't involve the physis, it cannot be a Sultaharis fracture. So remember, if you get confused, the metaphysis is the flared portion of any long or miniature long bones. And in a paediatric, you then have a physis, and sitting on top of the physis is your epiphysis. Once this physis has fused, i.e. the patient becomes skeletally mature and they stop growing, the whole portion of this becomes the metaphysis. So in an adult, we don't have an epiphysis, the entire distal portion is the metaphysis. So Sultaharis 3 is a fracture through the epiphysis, and remember that fracture extends from the epiphysis to the physis to become Sultaharis 3. Sultaharis 4 is through, so it's through the metaphysis, through the physis and out through the epiphysis. That's the Sultaharis 4. And finally for Sultaharis 5, this is rammed. So this is when the metaphysis and the epiphysis crushes together and basically rams or crushes the physis. And this is a really significant injury, because what will happen is it will lead to growth arrest. So as you can probably appreciate, 1 and 2 are the least significant injuries. Once you get to 3, it starts getting a bit more dodgy, but 4 and 5 really can be quite significant for patients. The Attilo fracture is a common paediatric ankle fracture. And what it actually is, it's a Sultaharis 3 fracture. And the reason why it happens is that the medial portion of the distal tibial physis fuses before the lateral portion of the distal tibial physis. And you tend to get this injury from a sliding injury, which you tend to occur in, say, baseball or skateboarding. And what happens is that you've got the anterior tibiofibrous ligament, which sits anteriorly, and what happens, it causes it to revulse, so you get this anterolateral displacement. And now on the lateral view, we can appreciate the anterior displacement. So on your mortise view, you should see some lateral displacement, and on the or varying degrees of lateral displacement, and on the lateral view you should see the anterior displacement. So this is your classic Sultaharis 3 fracture called Attilo. So what is it? It's a Sultaharis 3 fracture, Attilo, where it's the lateral distal tibial epiphysis. How? Slight anterolateral displacement. The other really common ankle fracture in paediatrics is a triplane fracture. So tri meaning 3 and plane, it's the different orientations the fractures occur in. So therefore you get 3 fractures in 3 different planes. Now on our mortise view, you can see there's a break in the cortex at the medial corner of the tibial plafond. So what happens is that you get a sagittal fracture running through the distal tibial epiphysis. And now on our lateral view, we can see now quite clearly that there's a horizontal fracture through the physis with a little bit of slip. And then we can see that there is a fracture of the posterior metaphysis, and it's an oblique fracture. So you get a sagittal fracture through the epiphysis, a horizontal fracture through the physis, an oblique fracture through the metaphysis. So when you see a single fracture in a pediatric ankle, scrutinise your images very carefully to see that you haven't missed some more fractures, in particular the horizontal fracture and the oblique fracture, to make it a triplane injury. So what is it? It's a Sultaharis IV fracture. Remember, there's a fracture that extends through the metaphysis, the physis and the epiphysis, so therefore it's a Sultaharis IV, where it's the distal tibial metaphysis, the physis and the epiphysis. How? So you've got a sagittal fracture of the epiphysis, you've got a transverse fracture of the physis, and you've got an oblique fracture of the metaphysis. And in this case, it's minimally displaced. Patients frequently sustain a chondral or osteochondral fracture of the talar dome. Now, what do I mean by osteochondral? So osteo is bone and chondral is cartilage. Obviously, if a patient sustains a chondral fracture, we won't be able to appreciate it because the cartilage hasn't ossified. But when we have an osteochondral fracture where both the cartilage and a piece of bone has been broken off, we are able to see it. And we normally see it on either the lateral corner of the talar dome or the medial corner of the talar dome. So it's important when you look at an ankle x-ray to always scrutinise the talar dome carefully. Now with an osteochondral fracture, what you're looking at are breaks in the cortex, and you should have a sharp lucence line. And this is particularly important because we'll just go and talk about an Osteochondritis Desiccant in a few moments. So what is it? It's an osteochondral fracture where it's the lateral talar dome. How? It's minimally displaced. We've seen this image before, but now I want to draw your attention to the medial corner of the talar dome. So when we talk about joints, we talk about the articular surface. And what we have here is a subarticular lucency. So what I mean is that the cortex is still intact, but just below, sub meaning below, just below the articular surface, we have this lucency. So what does this mean? Basically, this person has sustained trauma in the past. And what the most likely belief these days is that they have sustained an osteochondral fracture, and that osteochondral fracture hasn't healed properly. And when I say it hasn't healed properly, it hasn't actually stuck back on to the talar dome. And what happens is that you have this defect, and we can see that defect because there's increased lucency, because there's not as much bone density, because you have a piece of bone missing. So how do you differentiate between an osteochondral fracture and this appearance, which is described as Osteochondritis Desiccant? So with Osteochondritis Desiccant, you don't actually get a break in the cortex. If you look carefully, your cortex is intact. And then what you get is you get this reactive sclerosis adjacent to the subarticular lucency. Can you see how this is quite white here in comparison to the adjacent bone? And that means that you have reactive sclerosis to this previous injury. It's important that we identify Osteochondritis Desiccans, because what can happen, particularly in this instance, is that what you can get is a an intra-articular body that detaches, so the osteochondral fracture initially detaches and then basically turns into an intra-articular body, and this means that you can get early degenerative changes because the loose body is causing friction within the joint. So what is it? It's osteochondritis desiccans, where it's the medial talar dome, and how there's a subarticular lucency. Okay, let's just do a quick recap with the two different images adjacent to each other. So on our left we have our osteochondral fracture, so we can quite clearly see we've got a break in the cortex. We have a sharp lucent line. In comparison, osteochondritis desiccant is a chronic injury. So therefore the articular surface is intact because the subarticular lucency is below the articular surface, and then what happens is that you get adjacent reactive sclerosis to that lucency. If you look at the osteochondral fracture on the left, you don't have any reactive sclerosis. If you look at the trabecular pattern of the bone, it's all normal. So hopefully having those two pictures again side by side, this will give you a better understanding, differentiating between the two processes. I think that the important thing to notice with regards to the osteochondritis desiccans is that this is an additional anomaly in a patient who has sustained an acute fracture to their fibula. And this anomaly is not related to that fibular fracture. It's an incidental finding. Fractures of the talar neck are really significant injuries, and that's because the talus, like the scaphoid and the femoral neck, they all have a blood supply that enters distally. And they can be really tricky to see if they're undisplaced. Like this one's undisplaced, but we can quite clearly see the definite lucent line and the break in the cortex. They're sometimes referred to as an aviator's fracture because it was a really common fracture in patients in World War II who sustained this injury when their plane crashed. So what is it? It's a fracture where it's the neck of talus, how it's undisplaced or intra-articular. Like the navicular, the talus frequently gets tiny avulsion fractures to the anterior cortex. So when you scrutinise your ankle x-ray, make sure that you always check the anterior cortex to see if there are any teeny tiny avulsion fractures. On this particular image, we can see that there's really quite marked soft tissue swelling in association with this fracture. So what is it? It's an avulsion fracture where the anterior surface of the talus, how slightly distracted. I love this image. We can become completely distracted by the rather large fibular fracture and then fail to assess the rest of the image. If you do, you're going to overlook really significant injuries, such as this example. You need to use your search strategy AABCS in order to carry out a full evaluation. If we look carefully, we can see that the head of talus isn't articulating with anything. It's completely dislocated from the navicular. So what's happened is the navicular and calcaneum have dislocated laterally. And actually, surprisingly enough, it's normally a medial dislocation. About 80% of subtalar dislocations actually go medially rather than laterally. And it's important to identify on the AP the direction of dislocation, because it can be quite tricky with lateral dislocations to identify them on our lateral view. So let's keep going. And now we can see how it's so easy to overlook this. If you look at our talus, it's completely superimposed over the adjacent navicular. Remember, the navicular and calcaneum have moved laterally, and what's happened now is that it's been superimposed. So you need to check, so we can quite clearly see the the navicular and cuneiform joint space is maintained, and so therefore when you perform your image evaluation, always check to see, can you see the full joint spaces? And with this superimposition, you know that there's a dislocation. Had this patient sustained a medial dislocation, it becomes more obvious on the lateral view, because with a medial subtalar dislocation, you actually get the talus projecting anteriorly rather than being superimposed by the navicular. So what is it? It's a dislocation and fracture, where subtalar joint dislocation and lateral malleolus for the fracture. How? Lateral dislocation and a comminuted fracture. I really don't like the Bohler angle. I will teach it to you because it's pretty much in every single textbook, but I'll explain to you afterwards why I have a pretty low opinion of this of this aid to assess image interpretation. So when we draw in our Bohler angle, we're drawing two tangential lines. So the first is from the anterior aspect of the calcaneum, which runs all the way through to the superior aspect. And then you draw your second tangential line from the posterior aspect of the calcaneum, running through the superior aspect. And this angle here should be between 20 to 40 degrees. And so when patients sustain a calcaneum fracture, the Bohler angle frequently reduces to less than 20 degrees. So that's fine, except if you have patients with pes cavus and pes planus. So pes cavus, if you think about it, cavus is a cave, so people with little high arches, they've got a little cave that you can go into. So with pes cavus, you have an abnormally high Bohler angle. However, if you sustain a fracture, it's perfectly possible for that Bohler angle to become reduced, but because the person with pes cavus has a very high normal Bohler angle, when it becomes reduced, it could still remain within the normal range. In contrast, if you have somebody with pes planus, so flat feet, they have a really low Bohler angle, an abnormally low Bohler angle, and it's perfectly possible that when you measure that Bohler angle, it's less than 20 degrees, and so then you can assume incorrectly that they have sustained a calcaneal fracture, when in fact it's actually just their normal anatomical variation. So what I think you should do is, the most important thing when you look at your calcaneum is obviously check around the cortex of every bone, but in particular pay really close attention to the trabecular pattern. If you get an increase in density and a reduced Bohler angle, and the increase in density, that represents the crushing of the trabecula together, causing an increase in density, and that can be far more better clue of indicating an impacted fracture. Because if you think about it, the vast majority of people who sustain a burst fracture of the calcaneum is because of an axial force, i.e. something like falling from a height, and so therefore you're going to get impaction of the trabeculae. So this is a great example. So if you do use the Bohler angle, you can immediately see that yes, Bohler angle is far less than 20 degrees. But now let's look at our trabeculae. We can see this real increase in density where it's become crushed together, and then we've got our lucent line indicating our fracture lines. But perhaps the most important thing about this is always the comment on whether the subtalar joint is involved, because that has a significantly poorer prognosis for somebody with a crushed fracture to the calcaneum. So what is it? It's a burst fracture. Where is the calcaneum? How? It's comminuted with subtalar joint involvement. It's really important that you learn your normal variants because these can be frequently mistaken for fractures. They occur in very, very specific locations. The vast majority of them you see in the foot and ankle, although you can get them in the hands and wrists as well. But this one in particular that we're looking at is os subfibulare, and the reason why it's so important to learn what it looks like is because it can quite easily be mistaken for an avulsion fracture. So how do you tell the difference between an avulsion fracture and os subfibulare? Well, os subfibulare will be nice and round, it will be well corticated, and it will be smooth in outline, unlike a fracture which will be sharp, irregular, and it will be missing part of the cortex. And sometimes with or frequently with fractures, you will actually be able to identify the host location of where the fracture fragment has come from, which won't be present on an accessory ossicle. So we can see it on the lateral view projected as well in this location. So what, where, how, no bony injury, anatomical variant os subfibulare noted. The other anatomical variants that people get confused with is os subtibiale. Exactly the same to os subfibulare, except it's inferior to the medial malleolus instead of the lateral malleolus. So again, it's just familiarising yourself with the fact that it's well corticated, it's smooth in outline, and it's just in a classic location. So what, where, how, no bony injury, anatomical variant os subtibiale.